about the urinary, sorry. And however, the procedure was unsuccessful. So afterwards, subsequently, the bladder surgery was performed through the abdominal cavity, because as we know, the urinary bladder is found within the abdominal cavity. So using diagram from complete anatomy application, describe the peritoneal reflection of a urinary bladder upon the surgical procedure. So before I proceed, what I would like to explain is what my understanding as to what is peritoneal reflection. So I believe that peritoneal reflection is when we have regions that have a peritoneum where they are sort of like bending and facing each other, and thus where the name comes from, reflection. And you can see that these reflections, what they form is pouches, sort of like structures within the cavity. Okay, so the first peritoneal reflection that we can find within this the abdominal cavity is the vesico-uterine pouch, or also known as the Douglas pouch. So this is found right here, this green region, which this is the because our patient is a female, right? So this is the urinary bladder, and this is the uterus. So this is the peritoneum layer, which is not very visible, but if you were to see the connective tissue, there would be an area where the peritoneum sort of like folds here and face each other. And this green region is known as the vesico-uterine pouch, and it is one of the peritoneum reflections in the abdominal cavity. So next one is the recto-uterine pouch. So also another thing that I realized, right, you see the names, they actually make a lot of sense. So just now it was vesico-uterine. So vesico refers to the urinary bladder, vesico, and uterine refers to the uterus. So it is a peritoneal reflection found in between the vesico, which is the urinary bladder, and the uterus. So and this one is the recto-uterine pouch. So as the name suggests, it is found between the rectum and the uterus. So these are three different angles. So where it is found is the rectum is actually supposed to be here at the back, and there is a peritoneum here that covers the uterus, and also another peritoneum that would be covering the rectum. So that is where the peritoneal reflection is formed. This is just from so this is from the posterior view, and this is basically the whole thing that is inverted, and you are facing it from the posterior view, and this is pretty much the same thing actually. But yeah, it would be easier to. It was very difficult to get the rectum at the same time along with the genital urinary system, so we could only get the region where the recto-uterine pouch is found now. We couldn't get it along together with the rectum. So yeah, okay, next is the last one, which is the pararectal fossa that is found. So this is the rectum, this thing I am circling, and this region is the fossa. Fossa, as we know, is a cavity. So this cavity is formed by the peritoneum that surrounds the rectum, and also the peritoneum that surrounds I'm not sure what the other part it surrounds, but it forms a fossa basically. And yeah, that's about it. These are the three peritoneal reflections that you can find in the female's anatomical cavity. But if it were to be the male, there would be two more additional peritoneal reflections that you could be able to find there.
Just one question. What is para rectum?
Para, what I understand is
Around.
para because it's parallel, and rectal surrounding.
Let's say I'm the rectum.
Yeah.
Where's my para?
Around. Okay, Assalamualaikum and good morning everyone. Today I'm gonna illustrate and label the structure related to her urinary bladder. Okay, next. Can I see? Thank you. Okay, so basically in the urinary bladder itself, we have a couple of surfaces, border, angle, and also duct. So let's talk about it one by one. So for surfaces, we have the superior surfaces. Inferolateral means the inferior, below, and lateral, which is beside. Then we have the posterior surfaces. So we have 4 surfaces, 1, 2, which is behind, 3, and then 4. For border, we have it's like a line. So we have lateral, 2 lateral, 1, 2, and then anterior, 3, and posterior, 4. For the angle, we have the apex, which is at the tip, and then the neck, near the urethra, 2 posterior superior, which is here, posterior superior, and then 4 ducts, which is 2 ureters, 1 and 2, urethra, 3, and urachus. Urachus is not really visible here, but it's at here, around here. Why? Because urachus is a remnant of a bladder that will connect the bladder to umbilical cord. That's why it will regress as we age. Next. Okay, so this is the urachal cyst, and here is the urachal. Okay, next. Now I'm going to talk about anterior and posterior relation of the urinary bladder. Let's talk about anterior first. The blue writing is the anterior part. Now the anterior part of the urinary bladder is the retropubic space. So retro means behind, while pubic means behind the pubic bone. So retropubic space. Next, for the posterior relation, written in red, is the ureters, cervix, and vagina. Next. Now let's talk about superior and inferior lateral relation of the urinary bladder. Okay, for the superior parts, this is the behind view or posterior view. So for the inferolateral part, we have the levator ani and levator ani muscle and obturator internus, while the superior part is the stomach coil, which is above the urinary bladder. Next. So for the bladder bed, we have 2 muscles again. We have the levator ani in the middle and obturator internus, which is lateral to the bladder. Okay, next. Next. Okay, that's all for me. Thank you.
So first of all, I can see the most prominent part is the tricep muscle, which is so you can see that this outer layer is the tricep muscle. So when it contracts, it will kind of empty the bladder, because when it contracts, the volume inside relatively smaller, so it will expel the urine out of the fundus below it. So it is made up of smooth muscle, and then histologically it is also made up of 3 layers, which is the innermost is the longitudinal, nearest is circular, and then the outermost is the longitudinal as well. And then it is thick. It is thick because it has to withstand the high pressure when the urine is inside the urinary bladder, and it has to withstand the urine pressure inside this compartment. And then this muscle plays a very big role in nutrition, because alongside the wall it has the beta 3 receptor and the M3 receptor, which for the nutrition reflex, so it will like contract out for the urine to be expelled, for a small amount of urine to be stored inside this compartment. And then after we can see a trigon muscle, which you see, I don't know whether it's obvious now, but you can see this triangular shape is really
relatively more smoother than the detrusor muscle because detrusor muscle has the U-gate because it has to expand. And this trigon muscle is more smooth and then it is sensitive to expansion as well because the expansion will send signal to the CNS region and for the reflex to be conducted and then it will signal the brain should be enter the bladder. Then after that is an internal urethral sphincter and then it maintains the continence of the urine so it means by regulate the containment of the urine inside the bladder because when it contracts the urine cannot go out so the urine can be stored inside even when the bladder is full but you're not in an appropriate situation for you to expel urine so this is where the internal urethral sphincter comes into play. And then the interuretary ridge is actually this upper part of the trigon muscle. So it is full of mucous membrane. And then the trigon is basically, it forms like a boundary where the areas of the trigon muscle ends. Then lastly is the insula vesicae, but then it is kind of masked by the prostate gland. And then it's actually located in the middle lobe of the prostate gland. And then, it's a slight projection. Yeah, that's all.
Assalamualaikum and also good afternoon everybody. So today we'll be presenting the question compare the similarities and differences between the relation of the bladder in male and female patients. Next please. Okay, so to start, let's start with the similarities. So the similarities between the relations of bladder for male and female is that superiorly there is coils of intestine up here. And then infralaterally, there is both obturator internus and also levator ani muscle. This one I will explain further in the next slide. And then anteriorly, there's the, like Eddie said just now, the retropubic space, which is retro meaning behind and pubic bone, so over here. And then posteriorly, we have the ureter. Okay, so as I said, for both female and male, we have the obturator internus muscle and also the levator ani. This is for female and this is the male, obturator internus and levator ani. And then posteriorly, we have the ureter and also the ureter. Okay, so the differences for male and female is that posteriorly for male, as you can see here, there's the vas deferens here, and then we have the seminal vesicle here, and then we also have the rectum. The rectum is not in this image, but there's a rectum behind the bladder. And then for female, as you can see behind the bladder, there's the vagina. The fornix is not in this photo, but as you can see, it's here. So you can imagine that it's somewhere here behind the bladder. And then we have the cervix, this is the cervix, and also the isthmus of the uterus.
Can you go back? Sorry. So which one is the seminal cycle?
Sorry?
Seminal cycle. What do you mean by cycle? Seminal cycle? Which one?
Seminal
On the
vesicle.
diagram on the right side. Is it labeling correctly or what is it? You are showing the duct or the vesicle? Which one is the vesicle? What's your vesicle looks like? Apa itu vesicle? Betul vesicle tu kan? But the one is a duct atau tak? How the seminal vesicle looks like? Kena baik. What
Dia
I'm saying
bentuk
is that
macam leaf kan?
the labeling here, is it is showing the semi-normal cycle or the dark?
Dark.
Dark.
Dark, right? Be careful on that because sometimes you are intended to show the structures, but in this case it's dark. Alright. So kalau yang ni, yang center mana ni? Dah combine jadi apa? Never mind, you didn't do your reproductive model yet, right? Should be ejaculatory.
Oh.
Kan? Tak kan? Okay. Alright. Continue. Next.
So for one week, describe weekend innovation. So we do the patient has feels some kind of pain at the center of pelvis. So it indicates bladder referred pain. So this is the bladder. For bladder, the sensory nerves are divided into sympathetic nerve and also parasympathetic nerve, which is for the superior part of the urinary bladder, which is innervated by sympathetic nerve, which is, and then for the inferior part of the urinary bladder, innervated by parasympathetic nerve. So in our case, patient kita kan ada cartilage, so ada obstruction at the bladder. So nanti ada distension of the bladder, which will make this nerve to sense pain signal to the brain. That's all.
There's a diagram, very interesting diagram. Can you explain?
Oh,
But then okay pointer lah. Okay pointer. So because it's very important for nerve supply for your explain. It's an innovation.
so this one is parasympathetic nerve.
Balik.
This one is sympathetic
Ah,
nerve,
okay.
and this one is parasympathetic nerve.
Okay.
So these two is actually the sensory nerve untuk urinary bleeding. So kalau you guys can see the sympathetic nerve, it actually innervates the superior part of the urinary bladder. And then for the parasympathetic nerve, it innervates this area, which is the inferior part of the urinary bladder.
Let me add on. Okay, thank you very much. So this is how the innervations of your urinary bladder, right? So then for your this urinary bladder, they are received innervation from autonomic nervous system. You know it's autonomy, right? Things that you cannot control, they are involuntary. So they are controlled by sympathetic and also parasympathetic. Yeah? Remember the splenic nerve on the thoracic component, and there's this splenic nerve, all are sympathetic. But there's one parasympathetic splenic nerve only in pelvic. Because pelvic splenic nerve is a parasympathetic. Right. So remember the structures, the two muscles, right? And then you have internal urethral sphincter and also external urethral sphincter. So these two sphincter, which one do you can control? Internal or external?
External.
Internal you cannot control. Okay, now, so these muscles, and will be stimulated by parasympathetic. What do you mean by stimulated? So the muscle will contract. So the muscle will contract, high pressure in the bladder, that's why you push it out. At the same time, your internal urethral sphincter here, they are inhibited by inhibited. So what do you mean by inhibited? So the muscle will relax. So when the relax, then become open. So the urine can pass through. But at that time, at this time point of time, you still can control because you control here the external. Okay, I press the toilet now. There's a somatic system to relax the muscle. Okay, and then here the sympathetics will inhibit. Examples in the emergency. Takkan dia kata, kita asal di toilet. Tak ada kan? In emergency, there's no such thing that you know. That's why for sympathetic, because normally fight, that's why it's a sympathetic kan. And the time is inhibit this muscle. Bila inhibit means that the muscle relax lah. length dia tak contract. So the pressure dalam constant dia tak pernah pergi toilet. Okay. That's how the innovation is solved the urinary bladder, right? Because it's quite tricky there because somehow sympathetic spinal part they have a different function, and also for parasympathetic at different places they act differently. Okay, ada yang limit, ada yang stimulate. Right. Any question? I think you okay? Yeah, boleh. Okay, next.
So now we'll be presenting question 2. An 18-year-old man with base level injury sustained anterior urethral rupture. Urgent radiological examination was performed and localized bleeding was visualized. So this diagram is roughly what our patient has encountered. So this will be the anterior urethral rupture, this area here. So moving on to 2A, describe his presenting complications. So the first one would be hematuria. So hematuria refers to the blood in the urine. The presence of localized bleeding seen on radiological examination confirms the source of hematuria. So this diagram here, this yellow one would be the normal urine that you would see. And then hematuria is when you have blood, so the urine instead of yellow, you would see it red color, which represents blood. Second one would be pain and swelling. So there may be pain in the lower abdomen, perineum or scrotum, and as well swelling in the genital area can also occur due to the injury, because the area where the patient has his trauma is around this area. So moving on, third one, difficulty or inability to urinate. So anterior urethral rupture can obstruct the normal flow of the urine, leading to difficulties in urination. Urethral discharge. So in some cases, a clear or bloody urethral discharge may be noticed. Infection risk. With the rupture, there is an increased risk of infection due to the exposure of urinary tract to external contaminants. Moving on will be bruising. So bruising or discoloration of the scrotum can occur due to the injury and associated bleeding because the area of his trauma is around that area, around the scrotum. And then the last one would be potential long-term complications. So in the event the patient is not treated properly or appropriately, anterior urethral rupture can lead to long-term issues such as urethral strictures, which is tearing of the urethra, erectile dysfunction, and urinary incontinence.
Okay, before that, what is tracheal injury? What is tracheal injury?
Anterior fracture.
Tracheal contoh? Okay, if you fly then suddenly landing on that also tracheal. Okay, anything else untuk lain? You are standing and then someone Nick in the middle, it can be fast sound injury. This is a blind force. Alright, okay. Perhaps well, this person is very good to be oriented. That's why you come up with the long explanations. But the simple answer script is due to study injury resulting in extravasations of the urine and blood to superficial perineal pouch, scrotum, and interabdominal wall. Yes, what you do is dress the whole thing. No problem. So why there's an inflammation of urine in
Superficial perineal wall extravasation.
Sama juga yang ni.
wall? Why?
Oh, sama. Sama ni, sama. Oh. Shit.
Sorry? It's a fracture, right? Okay.
When the urethra is ruptured, then the flow of urine can spread to the
Correct.
areas.
Hilarious. Alright. But remember, for male external genitalia, they're covered by fascia, right? And one of the thick part is part fascia. Okay. So if because of this bulk fascia, it will limit the urine from going beyond that area. So that's why because of the because you done your lymphatic system, right?
Yeah.
How about the anterior abdominal wall?
Done.
Right. In general, your skin, it covers with superficial fascia and also deep fascia, right? So your superficial fascia, there are two components. One is campus and also scapula.
Yeah.
Right. So the campus will be fatty layer,
Yes.
and then scapula will be membranous layer.
Yes.
So this fascia, what is the fascia actually?
Connective tissue. Apa tu tissue?
What's the fascia? Sorry? What's the fascia?
Covering.
It's a membrane that will cover any organ and but even the muscle is covered. It's not fascia. The nerve is also covered by the other fascia. So it's a connective membrane tissue covering parts or bodies. Okay, so this fascia, the scapula fascia, alright. So it will continue downward, but in the perineum, it will continue as a Colles fascia. Okay, Colles fascia. So, but in the perineum, there's an additional fascia. It's a deep fascia in the perineum, Bart's fascia. Okay, you will learn that again in reproductive module. So because of this Bart fascia, that's why the urine will be limited, in the superficial pouch, slightly up to the internal wall, and also in the scrotum. So, because you need to understand the report first, you need to understand what I'm talking about. Okay, just remember because of the Bart fascia. Okay, another question. Kenapa? Why the urine didn't drain downwards towards your lower limb? Kita belajar kan masa lower limb. Why?
Apa ni soalan? Why the urine doesn't drain?
Kenapa? Kenapa tak boleh?
To the lower limb.
Katalah there is a pair of Bart's fascia. Kenapa dia tak drain ke bawah to your lower limb? You done your lower limb?
Because there's a fascia, so
Okay.
it's covered up.
So technically the Bart fascia inferiorly it will merge into the thick fascia of the lower limb. Kan? Bila dah merge, so there's no more space lah untuk urine ke bawah. Because of the what's the thick fascia in your lower limb?
Fascia.
Kan boleh tebal kan? That's the reason. Because Bart fascia they will inserted to the fascia. Alright, okay. Alright, next.
Good afternoon, everyone. So I will be presenting question 2B, which is using a diagram, describe the most likely affected part of his urethra. So in this injury, it will cause anterior urethral rupture. So it will affect the bulbous part of the spongy urethra. So actually there are 4 segments of the urethra. First is the prostatic part, which is at the neck of the bladder, and then the prostatic part, which is at the level of the prostate, and then the membranous part below that, and then the spongy part. So the spongy part is divided into 2, which is the bulbous before the second band here, and then the penile. So in this case, it will affect the bulbous area. And then this cranial injury is resulted from a forceful blow to the cranium, such as falling on a metal beam or incorrect passage from a transurethral catheter that fails to negotiate the angle of the urethra. So this will cause the extravasation of urine and blood to the superficial perineal pouch, scrotum, and the anterior abdominal wall. So here is the Bart fascia, and then if there's perforation, the blood or urine So this bulbourethral artery is actually a branch from the internal pudendal artery from here. Ha.
That's all.
But I have a question lah.
Yeah.
This pudendal artery kan actually also in female kan?
Also what?
In female.
Yes, of course. That's a pudendal artery. Unless vaginal artery, then different lah. Penile artery.
Kalau kita letak apa?
Because the question says that here, describe the sources of this bleeding. So it can be from any of the artery. So first it can be from the prostatic artery, of the internal cycles, of middle rectal artery, or branches of the pudendal artery. Even pudendal, which one is it? Internal or external? Internal pudendal artery, kan? So it can be any artery.
Kalau instead kita tulis ni, kita tulis prostatic branches of inferior vesicle.
Boleh? Possible. I mean, maksudnya it can be, there are few options for this type of cases lah. Maksudnya, it depending in which artery will be affected. Yeah.
But this one on the bulb,
Because bulbourethral artery from where?
the internal, the anterior part.
It's a branch of what?
Internal pudendal.
Into the pudendal, because it can be affected as well. Possible. Okay. But again, can you add to the questions yang baca? Okay, so localized bleeding. What do you mean by localized bleeding?
Means
This is ready.
it is at the region of the trauma and it hasn't gone into any other regions. Like it hasn't spread. The bleeding is contained within the
Contain due to what? Why
due to
contain?
the presence of the fascia.
What fascia?
The
Tadi sebut tadi.
Buck's fascia.
So because the bulk fascia is still intact, right? So the blood will contain that space. Kan? Itu masuk localized lah.
What's that thing? Update. Something.
Perhaps you are still not sure about this fascia thing because
What the?
you need to together with the
Okay.
module actually, for you to really understand the whole thing. Yes.
How do we spell the fascia?
FASCIA.
No, the front part of the
Sorry?
bulb fascia.
BUCK.
Buck's fascia. Just remember in our other part of the body there is a superficial and also deep fascia. The superficial is a camper and scapula. Camper is a fatty.
Itu
Scapula is
dia.
a membranous. So this membranous will continue, but in your perineum they become polys fascia. Kan ada kulit, polys, and then there's another one is a Buck's fascia. So this Buck's fascia actually they are covering the erectile tissues. Kan kita ada cavernosum and also spongiosum kan. Three erectile tissue they are covered by a fascia. What fascia? Kita bagi nama Buck's fascia. So all the blood vessels kat dalam kan. So kalau dia localized means they confine that Buck's fascia. Right. Okay.
Excuse me, Professor.
Yes.
You mentioned about how why if there is any damage towards the bladder, why the urine wouldn't spread towards the lower limb is because the Buck's fascia is joined with the fascia lata.
Means they continue inferior as a fascia.
Oh, they continue as the fascia. Oh.
Because fascia actually they are continuous to each other. It's just that at different places we give them different name.
Oh, but they're all a single tissue. Actually,
Yeah, but certain places become thicker.
Ah,
Like fascia lata kan.
yeah.
So they are continue each other. So they are not in silo. They are not okay. This one fascia only. Tak, tapi they are continuous. It's just that we give them different name. Sama macam peritoneum, kan? Bila peritoneum, and then sometimes you refracted tu.
Yeah.
Tempatan ada space. Then kita bagi fossa lah. And this peritoneum actually they will cover the organ, right?
Yeah.
Okay, organ kalau small intestine. So dia dah cover small intestine, dia jumpa balik tu.
Yeah.
Dan jumpa balik kita panggil apa? The peritoneum, kata lain ni small intestine kat sini kan. So the peritoneum, and then cover, dan yang ni macam kita boleh jadi apa?
Oh,
Oh,
intestine kita panggil mesentery kan.
mesentery.
Kalau dekat stomach kita panggil apa?
Mesocolon. Mesocolon.
That one's for
that
large
is
intestine lah.
large intestine, yeah.
Mesocolon. Tapi kalau dekat stomach,
Stomach. Mental.
all the mental.
mental.
All are peritoneum.
Yeah.
Semua peritoneum. It's just that at different places, they cover organ lain. Then we give them different name lah. Otherwise you confuse nanti peritoneum mana. So that's why the specific name lah. So kalau yang saya panggil apa mesentery, so yang dari intestine apa pula? The stomach, all are actually it's a one continuous peritoneum. Alright, okay. Any more questions? Lagi dalam 20 minit. Atau kau nak balik awal? Anything? So I hope you understand because the main idea for today's is more for your urinary system, and for urinary system for anatomy component is not that major. The most important will be physiology. Ya. Dia banyak kan? Anatomy only few hours je guys. Tak banyak.
Yeah.
Okay. Alright. Are you happy? Boleh?
Yeah.
Kau tak faham? Anything? Tak ada? Okay, thank you very much.
Alright.
Tadi
Enjoy your
tadi
life.
yang urine spread tu maksudnya dia macam bladder dah pecah lah.
Sorry?
Yang kenapa urine tak spread ke lower limb, dia punca dia sebab apa, bladder dah pecah lah.
No. Kau bukan
I
bladder
mean
macam
ada
facial
ada
data
trauma.
kan?
Tak, I mean like kenapa urine dah nak spread, like what is the cause lah. Kenapa
yeah.
urine bocor sebab
Sebab
like there's a
pernah-
hole or something lah, ada trauma lah.
Ya trauma.
Oh, okay.
Leakage.
Leakage.
Berarti dengan Indonesia tak?
Banyak habis.
Okay. Okay. Tetap. Yang mana tu? Yang depan.
I don't understand like how innovates yang dia inhibit the estrogen muscle kan yang atas tu for sympathetic.
Betul.
So bila dia inhibit, meaning that they cause the relaxation of the estrogen muscle. Lepas tu yang bawah intellectual center tu dia constrict ke macam
Dia tak konsep. Okay. When you say negative means what? Negative. Inhibit lah. Kan? Maksudnya relax lah. Kan? And then bila positif, dia stimulate. Berapa tu dia masa? Constrict. So, kalau dia relax, contoh, Mark and start respond Okay. So, ni will be activated. You tak boleh ada dua activated at the same time. Kan? Satu, one will be orang kata the main ni lah. So, sympathetic kick in. So, that can inhibit this muscle. Relax. But at the same time, activate. Constrict lah supaya duit tak terkeluar. Duit nak berlari, nak bergaduh, nak berkejar-kejar. Kan? So, ini kena constrict. Lebih lah supaya duit tak terkeluar. Kan? Nanti bila dah penat, you relax. Kan, you dah rehat. Now, para kick in. Because para to make yourself relax kan. You calm down. Tetapi there are certain organs in our body will be activated by para. One of that is the
Urine. Bladder.
bladder.
Ah.
Bila anda panas pada tip, your bladder will be activated or the susu muscle tu active. Dan dia contract. Betul tak? Bila contract, what happen to the pressure dalam tu?
Increase.
Increase tu, dia dah tolak urine ke bawah.
Mhm.
Tetapi dia tak ada internal training kan. So how to make them relax? At the same time, para will cause this muscle relax a little bit. So you boleh turun. But the final decision will be you.
the external.
The external because you boleh control gender, betul tak? Kecil nanti tapi saya sempat pergi sana. Okay, kalau sampai sana you relax, keluarlah urine. Is there any organs in our body that activated by parasympathetic other than this military? Tak organ lain.
Organ lain banyak.
Erection
Sorry?
Erection
Okay, right. Reaction due to
due to parasympathetic.
reaction due to parasympathetic,
Yes.
tetapi ejaculation
Is sympathetic.
sympathetic.
Yeah.
That's why sympathetic dia tutup.
Ah,
Kan?
yeah. Faham?
Supaya semen boleh keluar.
Oh, yeah, yeah.
Kan? Okay. How about organ lain? How about your stomach, your GIT?
Oh, increase in motility.
Masih bila dia aktif?
Parasympathetic. Parasympathetic.
That's why bila you dah rasa rehat, then you suddenly boleh dengar perut you kecil kuat
Yeah.
kan. Masa dia aktif. Dan you pun mengantuk because most of the blood hantar kat perut. Bila blood kurang, then what happen to your brain? You mengantuk lah, tak cukup
Yeah.
oksigen tu tak? That's why untuk makan tengah hari, kalau ada kelas petang, janganlah makan heavy sangat kan. If you eat heavy meals, then what happen in the afternoon?
Sleep.
Masa kelas.
Ngantuk.
Mengantuk. Because more blood concentrating kat badan perut.
Now I understand the direction.
Kan? Okay?
Faham.
Boleh?
Aku masih buat juga.
Any more? Yes.
Kena letak makanan kat otak tu.
Correct. This is a motto. It's motto. Tapi yang ini talking about the pain innovation kan. Pain innovation also kata, of course, kita ada somatic dengan autonomic. Somatic kita ada afferent and efferent, betul?
Yeah.
So autonomic sama lah, afferent and efferent. So in this case, untuk pain, dia daripada, yalah, dia punya afferent je lah, kan? Untuk afferent, dah upper part, daripada sympathetic, lower part daripada parasympathetic. Contoh pain apa dia? Contoh pain. Contoh sakit yang dibawa oleh dia, apa dia?
Sakit.
Ayolah jual ni pain innovation ni.
Epilator bukan? Bukan.
If your blood is,
Ada kan
I mean, up to the maximum level, dah penuh dengan urine, what do you feel? Painful?
pain,
Yeah.
yes.
Ni lah dia yang dibawa tu. Kau tak tahu dia rasa pain. That pain actually is detected by afferent fibers of the autonomic nervous system. Boleh? So remember, somatic ada dua, afferent, efferent. Autonomic sama ada afferent, efferent. It's just that for this one, we're talking about motor lah. Kita bincang ini, it's motor.
Professor, so does that mean that the same nerves that are involved in the innervation of the motor movements is the same as the pain innervation, or is
Yeah,
it
of
it's the
course.
same?
Because in one nerve,
Yeah.
it consists of thousands of axons, right? So some will be motor, another will be sensory, afferent, efferent. Remember how the spinal nerve are being formed? It's a union of sensory and motor. Same thing with autonomic. It's a union between motor and sensory. It's just that the lecture we're not really spell out the sensory part of the autonomic nervous system because still will be very
Dan
complicated.
dia
Kan, betul tak?
sebenarnya terlibat sekali untuk pain innervation.
Ya.
Sekali.
Sekali. Sebab nerve.
Great. Alright. You are more than free to knock my door and then tanya lah. Tapi saya tak stay sini je, saya tak boleh say, kalau nak just text me. Okay? Alright, okay. Thank you.
Thank
Thank you,
you.
Professor.
Bye.